Hello, my name is Anna Vega. I'm an infectious diseases pharmacist at Jackson Memorial Hospital, and in this presentation, I will be giving an updated review of pertinent drug information for SARS-CoV-2 as it relates to Tocilizumab and the other IL-6 antagonists. As mentioned in the previous version of these slides, Tocilizumab is a humanized monoclonal antibody against the human interleukin-6 receptor. By binding both membrane-bound and soluble forms of the IL-6 receptor, Tocilizumab competitively inhibits the action of interleukin-6, which is an inflammatory marker that's produced by many of our body's immune system cells. The pathogenesis of previous coronaviruses like SARS and MERS suggests that a cytokine storm is involved, which leads to inflammation in the body and pulmonary damage, potentially pulmonary fibrosis. And one of the main markers that's associated with cytokine storming is interleukin-6. So the thought behind this drug is that by blocking the action of interleukin-6, we're able to stop some of the progression of disease associated with COVID-19, including potentially ARDS. For more information on mechanism of action, drug interactions, and dosing of Tocilizumab, please refer to the first version of these slides. A lot of the new information regarding Tocilizumab that has come out in the past couple of weeks has been in the form of case reports and case series, as more institutions around the world are beginning to use this drug for this indication and starting to publish their experiences. One such case report describes COVID-19 disease in a 42-year-old man with a past medical history of renal cell carcinoma. The patient was admitted for fevers as well as symptomatic bone metastases. On day 6 of the admission, he developed cough and fever and tested positive by PCR for SARS-CoV-2. On day 7, treatment was initiated with lopinavir, ritonavir, or Kaletra, as well as antibiotics including piperacillin tazobactam. On day 8, he had an acute desaturation and required 6 liters of supplemental oxygen. His CRP increased to 225, and on this day, he received 2 doses of Tocilizumab at 8 milligrams per kilogram, 8 hours apart. On day 12 of this admission, it's reported that his supplemental oxygen was discontinued. He had improvement in his CT chest. He became afebrile, and that this occurred rapidly after Tocilizumab, although the original fever is not described. And also his CRP decreased from the previous 225 figure to 33. So it didn't normalize completely, but it did decrease. A similar case report describes the use of Tocilizumab in a patient with COVID-19 and a past medical history of multiple myeloma. This case report describes a 60-year-old man who was working in Wuhan, China, and was admitted for chest tightness with a CT chest demonstrating multiple ground glass opacities and pneumatocele bilaterally. SARS-CoV-2 diagnosis was made by PCR. The patient was initiated on antibiotic treatment with moxifloxacin, 400 milligrams IV daily for 3 days, as well as an antiviral available overseas known as umifenavir for an unknown duration of time. As mentioned, the patient had a history of multiple myeloma that had been diagnosed in 2015 and from which he had achieved full clinical recovery after chemotherapy. On day 15 of illness, the patient was readmitted with acute shortness of breath and desaturations to about 93% on room air. And at this time, he was started on steroids, methylprednisolone, for 5 days. On day 24, so day 9 of the illness, of the second admission, he had chest tightness that persisted, and also the lesion on his CT chest persisted as well. So this led the authors to give a dose of Tocilizumab, 8 milligrams per kilogram times 1. On day 27, it's described that his chest tightness resolved, and finally on day 34, a third CT chest had improvement in the lesions, and the patient was successfully discharged. In this figure, we can see the clinical course for the second admission, which encompasses day 15 to 34 of illness. We can see that the patient presented with chest tightness, which is what originally had brought him to the hospital 15 days prior. However, more concerning, the patient did present this time with shortness of breath and oxygen desaturations, which led the authors to prescribe steroids. And it looks like these steroids did help improve the patient's symptoms acutely. However, the chest tightness persisted, and his CT lesions, as one would expect, were somewhat slow to resolve. And while these two things alone may not be enough criteria for many institutions to pull the trigger on using this drug, it looks like the authors were also guided by inflammatory markers, as they have trended the IL-6 here. Interestingly, we see that IL-6 was quite elevated, with a normal level being described as 7. And after giving tocilizumab, it did decrease, although it didn't fully normalize on day 18 of this second admission, with a subsequent peak on day 21. This has been seen anecdotally in other reports, and one theory is that because the drug is binding the receptor, there is more free IL-6 in the serum, and therefore we see this peak after the dose is administered. These two other case reports that I will be presenting, unlike the first two, are cautionary case reports that describe two patients that did not do so well, even though they did receive tocilizumab. The first case report describes a 40-year-old man with no past medical history who presented with 5 days of fever, dry cough, and dyspnea on exertion. He was confirmed to be positive for SARS-CoV-2 by PCR and started on hydroxychloroquine and azithromycin. Hypoxemia progressed, requiring mechanical ventilation 2 days later. The patient then went on to develop ARDS on day 4, as well as septic shock, and was started on pressors. At this time, tocilizumab 400 milligrams flat dose was administered. And unfortunately, we do not have the patient's weight to estimate what type of dose this was. The next day after tocilizumab, the patient developed a STEMI and was diagnosed with viral myocarditis. And on the following day, the patient was febrile to 109 degrees Fahrenheit, a very high fever, in septic shock, refractory to 4 pressors, and eventually passed away. The second similar case describes a 69-year-old woman with a history of type 2 diabetes, rheumatoid arthritis, and aplastic anemia, who presented with 6 days of productive cough, pleuritic chest pain, fever, fatigue, and abdominal pain. On exam, she was febrile, she was saturating 95% on room air, and a CT chest showed diffuse bilateral nodular opacities. On hospital day 2, she rapidly progressed into respiratory failure and septic shock, and she was intubated, started on pressors, and treated with 1 flat dose of tocilizumab, 560 milligrams. Again, her weight was not provided. On day 3, the shock worsened. She required max dose of pressors, and on day 4, she received a second dose, this time of 700 milligrams IV. And despite the second dose, the patient passed away. Here, of course, we do have a lot of missing information in terms of the clinical course and the patient's comorbidities. However, this brings to light that this drug, we still have a lot to learn in terms of the correct timing of administration and perhaps other adverse effects. And we don't have a lot of information in terms of giving this drug once a patient is already in septic shock. And many have cautioned that since there is already an increased risk for infection with these agents, that perhaps this is not the correct time to give these medications. So, of course, as more information comes out, we will know more about the dosing and the timing that is best, if any, for benefit with tocilizumab. Next, I want to describe a tocilizumab case series that included 15 patients with varying disease severities. And the disease severity definitions were taken from the 5th edition of the Chinese Clinical Guidelines for COVID-19. Most of the patients in this study were critically ill, requiring mechanical ventilation, or they had shock that required ICU care. Severely ill patients included those that had tachypnea with a respiratory rate greater than 30, an oxygen saturation at rest of less than 93%, or a PF ratio less than 300. Moderately ill patients were those that had fever, respiratory symptoms, and radiological signs of pneumonia, but did not meet any of the criteria for severe or critical illness. And this included only 2 patients in the study. The interesting thing about this case series is that there is a very wide variation in clinical practice in terms of what doses the patients were administered, both amount and quantity, and other agents that were used in conjunction with tocilizumab. The doses for tocilizumab in this study ranged from 80 to 600 milligrams, and 8 patients received tocilizumab in combination with steroids, namely methylprednisolone. We kind of assume that other therapies must have been used in these patients, including supportive care, but this is not described in the text. The median age for the cohort was 73 years, and the authors found that 3 patients after tocilizumab was administered eventually did pass away. Improvement was seen in only 1 patient. Stability or lack of progression was seen in the majority of patients, 9 patients, and aggravation was seen in 2 patients. The exact definitions of these different criteria or categories are not described. So we don't know if stability meant that you didn't need more oxygen, or maybe they were looking at other parameters as well. Baseline elevations that were seen in CRP returned to normal in 10 of the patients, and IL-6 levels did not return to normal in any of the patients. And this is kind of going hand in hand with some of the other information that I presented regarding trends in IL-6 levels after tocilizumab. The authors concluded that a single dose of tocilizumab seems to fail to improve disease activity in critically ill patients. However, repeated doses might improve the condition of these patients. In this table on the right, I want to highlight some of the clinical variation described in this study in terms of clinical practice. We see here that for critically ill patients, numbers 1 through 7 on this table, they received anywhere from 80 to 600 milligrams of tocilizumab. Some patients received 2 doses, others received 3 doses. Sometimes the repeat dose was higher than the original dose, but for example, in patient 6, we see an original dose of 80 milligrams followed by 160, then back to 80 milligrams. And the same variations are seen with methylprednisolone. So it's unclear and difficult to draw conclusions on which patients should receive these lower doses or why these lower doses were chosen, in addition to which patients may benefit from steroids in these regimens. In addition, the Chinese clinical guidelines, the 5th edition, still recommends 4 to 8 milligrams per kilo of tocilizumab with a max dose of 800 milligrams. So it would be really interesting to see how the authors arrived at these different doses, especially considering that their conclusion is that critically ill patients may require repeat lower doses to show some benefit. Other limitations of this study are that patients were followed for 7 days only. So considering that the half-life of this drug is quite long, it would be good to know what happens to these patients after a week of receiving the medication. Concomitant therapies are not described, as I previously mentioned. Baseline characteristics are missing entirely, so we don't know how many of these patients had a long list of comorbidities that may have influenced their clinical course. And we also don't know how many were, for example, immunosuppressed at baseline, which could have also influenced their progression of disease. They also don't mention exactly what they mean by improvement or stability, so we don't know if they looked at only the requirement of oxygen or fever curves or symptoms, for example. And lastly, adverse effects are not described. Switching gears to a single-arm prospective study of tocilizumab for patients with severe COVID-19, this study took place across 4 different hospitals in Italy, and at the time of this recording, with 63 patients included, this is the largest study of tocilizumab for this indication that we have at this time. In order to be included in this study, patients had to have all 3 of the following: PCR confirmed SARS-CoV-2 infection, an oxygen saturation of less than 93% on room air, or a PF ratio less than 300, and at least 3 of the following increased inflammatory markers, including CRP, ferritin, D-dimer, and LDH. This is interesting because this is the first time that we see inflammatory marker elevations as strict inclusion criteria for receiving this drug. In this study, patients received either 8 milligrams per kilogram IV of tocilizumab or 324 milligrams subcutaneously once, although 52 patients, a majority of the patients, did receive a second dose of the drug within 24 hours of the first dose. The primary endpoint was safety, and secondary endpoints included improvement of respiratory and laboratory parameters. The authors performed several statistical tests, including a multivariable logistic regression, to identify predictors of poor prognosis. However, you will notice in the results of this study that the factors included in the multivariable logistic regression model are not described. In terms of results, the average age of the cohort was 62.6 years. The authors described no severe or moderate adverse events in their population. However, although this was the primary endpoint, there is some lacking information in the study in terms of how they performed their safety analysis and what types of adverse events they were recording or looking for over what period of time. There was a significant decrease in the average CRP and D-dimer by day 14, as well as a significant increase in the PF ratios on average of their patients. So these are 2 positive findings. They make a statement at the end of the paper that tocilizumab within 6 days of admission was associated with increased likelihood of survival and present a hazard ratio of 2.2. However, in their Kaplan-Meier curve, they compare the likelihood of survival with the level of the D-dimer. And they have a sort of arbitrary threshold set here for the D-dimer. So it's unclear exactly where they got the 6-day threshold from in terms of timing of administration of the drug, and perhaps they got this from the logistic regression, but as I mentioned, the details of this evaluation were not described. In the end, the authors concluded that their data suggests a promising role of tocilizumab in terms of efficacy and highlights the safety profile of tocilizumab for COVID-19. Lastly, for tocilizumab, I want to mention that there may be some promising data coming out from France that made some waves in the press last week. This study was looking at patients with severe or moderate COVID-19 pneumonia in a French multi-center open-label randomized controlled trial, which is part of the Corrimuno platform looking at various randomized controlled trials for the COVID-19 agents. They looked at patients who met their criteria of moderate or severe, which has not yet been fully described until the data is published. But they mentioned that these patients were not requiring invasive care or ICU care upon admission. The primary composite outcome was need for ventilation or death at day 14, and ventilation included both non-invasive modes and mechanical ventilation. A total of 129 patients were randomized to receive the drug with standard of care versus standard of care alone. And the press release mentions that a significantly lower proportion of patients reached the primary outcome in the tocilizumab arm. So more to come in this area. Watch out for this publication. Now I want to focus on the other IL-6 antagonists, Sarilumab, brand name Kevzara, and Siltuximab, brand name Sylvant. These drugs have been receiving some attention since they have the same mechanism of action as tocilizumab. Sarilumab is FDA approved for rheumatoid arthritis. The dosing for this indication is 200 milligrams subcutaneously every 2 weeks. And of note, this drug is only available subcutaneously at the moment. Precautions include not initiating if the ANC is less than 2,000, platelets are less than 150,000, or the transaminases are elevated. And a U.S. box warning includes a risk of serious infections. Siltuximab is FDA approved, on the other hand, for multicentric Castleman's disease. The dose here is 11 milligrams per kilo IV once weekly or once every 3 weeks. Again, we see a recommendation to consider delaying treatment until the ANC, platelets, and in this case, the hemoglobin have normalized. And there is a risk of infection also as a consideration with this agent, although unlike for Tocilizumab and Sarilumab, it is not a boxed warning. Sarilumab, similar to Tocilizumab, has also made some recent waves in the press. The drug company Sanofi just published results of a phase 2 study comparing 400 milligrams versus 200 milligrams versus placebo in 457 patients, most of which were critically ill, meaning that they required mechanical or high flow oxygenation or were in an ICU. Some patients did have multi-system organ dysfunction, and the rest were severely ill, meaning that they required oxygen but not mechanical or high flow oxygenation. The Independent Data Monitoring Committee recommended continuing the ongoing phase 3 trial only in the more advanced critical group with only the higher dose of 400 milligrams versus placebo, since there was some promising results in this area. In this table, we have the phase 2 efficacy results as published by the company for the both 200 milligram and 400 milligram high dose of Kevzara or Sarilumab compared to placebo. We see here that the primary endpoint chosen by the company was % change from baseline and CRP, and one could argue that this is not truly a significant endpoint in terms of disease, COVID-19 specifically. Nonetheless, the authors did find a 79% reduction in the high dose group compared to a 21% reduction in the placebo arm. And of course, we would expect this drug as an IL-6 inhibitor to decrease some of the inflammatory markers in our body. So we're glad that they did find this. And then in terms of the exploratory clinical endpoints, the data is presented only for the critical group, so we'll never know how the drug performed for the severe group. However, we do see here there was some signal of benefit. For example, patients that were in the high dose group, 400 milligrams, that passed away or had to be placed on a ventilator was 32% of patients compared to 55% of patients in the placebo arm. Similarly, more patients in the high dose group achieved clinical improvement compared to patients in the placebo arm, 59% versus 41%. So hopefully we will have the data published soon from the phase 3 study to be able to draw more conclusions about Sarilumab for COVID-19. For Siltuximab, the only data available is this 21 patient case series that looked to evaluate treatment response of the drug in patients with ARDS and COVID-19. All patients received standard of care, which was not described, and Siltuximab 11 milligrams per kilo once, IV, with 5 patients receiving a second dose. The median age of this cohort was 64 years. The median PF ratio was 127, which would be moderate ARDS, and 100% of the patients required non-invasive ventilation. So of note, none of these patients were mechanically ventilated. 85.7% of patients received Siltuximab within 24 hours of non-invasive ventilation and 100% within 48 hours. In terms of the results, improvement was defined as a reduced need for non-invasive ventilation, which was found in 33% of patients. Stability was found in 43% of patients. It's unclear if this means that their vent requirements didn't change, but this is the majority of patients in this cohort were found to be stable and non-progressing. And worsening requiring intubation or death was found in 24% of patients. So we see a hodgepodge of results here. The baseline elevations seen in CRP all returned to normal limits by day 5 for this drug, as we have seen with some of the other IL-6 antagonists. And the conclusions of the authors was that there is a potential role of Siltuximab in treating patients with SARS-CoV-2 infection who develop pneumonia and ARDS that requires non-invasive ventilation. In terms of other relevant clinical trials, there is a lot of movement in this area, which is very exciting. I've listed here some of the trials on clinicaltrials.gov, and I've linked them for you here as well to the website for the 3 agents. Of note, for Tocilizumab and Sarilumab, there are randomized controlled trials underway with hopefully some more information available for COVID-19 in the next couple of weeks. For Siltuximab, we have some open label trials and observational case control studies, but we don't have any randomized controlled trials yet. In summary, Tocilizumab, Sarilumab, and Siltuximab are humanized monoclonal antibodies against the human IL-6 receptor. Since cytokine release syndrome may be involved in the pathogenesis of SARS-CoV-2 infection, these agents are under investigation for COVID-19. Currently available data that I presented is mixed for Tocilizumab, with a recent 63-patient single-arm prospective study demonstrating some potential benefit. Sarilumab phase 2 trial results demonstrated a signal of benefit for patients with critical but not severe disease. The data was not shown. And more robust data on Siltuximab for COVID-19 should become available soon before conclusions can be drawn. Safety profiles for all of these agents include an increased risk of infection, and randomized clinical trials are currently ongoing for Tocilizumab and Sarilumab, and we await for these results to be published. For Siltuximab, we do have some data, but not randomized controlled trials at this time. Thank you.